Okay, welcome everyone to this noon meeting, which is happening virtually. As you can see, I am going to introduce the speaker, who is Dr. Lawrence Loh from Canada. It's a noon meeting being hosted by the Division of Public Health Medicine, and we're very pleased that one of our former registrars, Nazia Pia, who I see lurking in the guest list, put us in touch with Lawrence. Lawrence was supposed to be in Cape Town to actually give this noon meeting in person, but we live in a different world now. So Lawrence has gotten up very early in that part of the world to do this noon meeting. We're very appreciative. Lawrence is what we used to have in South Africa called a medical officer of health. I guess that's our common colonial tradition with the British. And he's responsible for the region of Peel in Canada. He's also an adjunct professor at the Dalai Lama School of Public Health in Toronto, University of Toronto. He's a medical doctor with an MPH and is also board certified in family medicine and preventive medicine in both Canada and the US. So as a medical officer of health, he's responsible for public health matters to the regional council and provides direction to a complement of public health staff for a program that uses a population health approach focusing on upstream efforts to prevent disease, improve health, and address differences in health outcomes amongst and between groups. So he's going to be talking to us about health equity in pandemic times and his experience from Peel region in Ontario, Canada. And thank you so much for joining us, and over to you. I will now switch off my video and
no problem.
To you.
Thank you so much for the warm welcome, Dr. London, and I'll switch off my video as well, but I did want to just briefly let you see where I'm at here. And thanks as well to Simfui and Carmen, and also to Nazia for setting this all up. And as was said, I think 2020 has not unfolded the way it was anticipated, I don't think, for anybody, but certainly hope to be able to visit South Africa someday and actually present in person. Also, what Dr. London neglected to mention as well is that this presentation originally was not meant to be about a pandemic. And in my bio, I think one thing I'll also add is I took the reins of our health department at the region of Peel in mid-March, just as the pandemic was arriving on our shores here in Canada. So when I talk about it being an unusual year and not being one that any of us have anticipated, I would be happy to argue, perhaps none so more than me, just in terms of having taken over at the time that I did. But I think it's been great learning, and I'm hoping to share some of that learning with all of you today, and also really just emphasizing that in my role as a medical officer of health, my focus is in leading a public health department. And as many of you know, in your School of Public Health and Family Medicine, I think we share a common understanding that public health is really about the interventions, creating the contexts that keep people healthy and keep people out of the healthcare system in the long run. Certainly, at least in Canada, the typical focus on that has been in chronic disease prevention, although there's been some remaining communicable disease threats, certainly environmental health. It's really odd for me to be saying a lot of these, just given how the focus of our department has been over the last 7 months. But we also understand, of course, that especially in a pandemic time, public health really is the first line in terms of trying to interrupt transmission in the community through policy, through programs such as case and contact management, and through coordination and communication with partners and with public education. And so I'm going to speak to a little bit about how our pandemic response has gone in Peel, and then a focus, at least in terms of our learnings around health equity. So I'll turn my camera off now and we'll get into the slides. All right, so just a brief overview, and I should state at the outset, I realize I neglected to put a slide, but I have no conflicts of interest to declare in relation to any of this content, and no declaration of pecuniary or financial interest whatsoever. But I'm going to provide a bit of an overview on the public health system as it's structured in Canada and Ontario. Then I'll talk a little bit about what we see in the region of Peel in terms of our understanding of our community and the health aspects there too. Certainly the actions we've taken to mitigate in our pandemic response, the questions around health equity that have arisen, and then our action areas ahead before launching into a little bit of a discussion with all of you. So, as I've described, public health is really in Ontario, as I imagine elsewhere in the world, its entire focus is about protecting, promoting, and optimizing the health of the population. I usually explain it to my students and also my clinical peers as public health is essentially trying to get people to live better for longer and really trying to keep people out of the healthcare system in the first place, be it through prevention, promotion, all these other all the other key programs that really create the context for good health in our community. In Ontario, we consist of 30, and this is a typo, and that was another typo I neglected, but we're actually 34 public health units. And these are official agencies that are guided by a provincial mandate and are governed by a local board of health. A lot of these health agencies are legislated under the Health Protection and Promotion Act to serve a specific community. So, for example, the City of Toronto, to the east of us, has a health department that serves it. And then in the northern parts, there is maybe one large health department that may serve a number of municipalities, but the idea is that there's 34 of them. The idea is that these local boards of health are meant to inform municipal decision makers around patterns and trends that are observed in our communities and around measures that can be taken to address them, whether it is something slow burning like the chronic disease prevention file, or if it's something fast moving in an emergency response such as the COVID-19 pandemic. In terms of their funding, they are cost shared by the provincial government of Ontario and the local municipality. So in Canada, we have a disseminated federal government. We have basically the Canadian government at the federal level, and then we have 10 provinces and 3 territories, which are then at the sort of broader provincial level, and then below that we have local municipalities. So Peel being in Ontario is the local municipality is Peel, the provincial government is Ontario, and so the costs are shared between them, where our public health funding is funded 70% by the government of Ontario and 30% by the local municipality, in recognition of both the value of strong public health measures in protecting the population broadly at the provincial level and under the Canadian Constitution, where health is a defined provincial responsibility, but also an additional local cost share with the recognition of the specific expertise and service level that local municipalities receive from a public health unit that is circumscribed to their region. They are autonomous and led by a medical officer of health, and they report into the local board of health, which can take many different forms. Either the local board of health is also autonomous, or it may be the actual regional council of elected representatives, as is the case in Peel, or it may be a mix of the two, where there are some elected representatives and also some members of the board of health to which it reports. And at this time, the public health system in Ontario is under review. As I imagine may happen in South Africa, and I don't know, Leslie, if you're referring to this in your opening remarks. There's always this push and pull in public health structure and governance around whether public health is best placed outside of the healthcare system or within the healthcare system. Certainly recognizing, of course, that we share goals in common, but we don't necessarily always share a common goal with the healthcare system. This is currently where some of the discussion is around: do we want to reduce the number of health units? Do we want to embed them within local health authorities, healthcare authorities, which also oversee hospitals, etc.? So that was actually, and ironically, an important factor in our pandemic response. Because there was a significant restructuring that was announced in spring of 2019 that led to significant turnover and perturbations in the system, along with an announced funding cut. which, as you can imagine, through a course of consultations over 2019, led to the loss of a lot of staff, led to a reorganization of resources that, when the pandemic arrived in 2020, may have put us a bit back on our back heel. So I think the picture that we eventually did have in Ontario, taken within that context of the restructuring and review that was undertaken in 2019, actually points to even more significant work that has been done to really, I think, keep the population safe through this pandemic. But it's a discussion that continues to unfold here in Ontario, as I imagine it unfolds everywhere else around the world, as to what extent should public health be coordinated with healthcare, and to what degree should they be governed through the same tables and through the same planning processes. So that's the last bullet there. But so we'll talk a little bit about now what we did here in the province of Ontario, and it's very interesting. I'll start out by saying our health unit was, among other provincial health units, not one that was caught flat-footed. We were in emergency operations since mid-January, once word of the virus was coming out of China. I'm certain for all of you, as I watching on at that point in time, the idea of a significant lockdown and closure of a city of 11 million people in central China was at the time for us, it was simply a confirmation of our already growing concerns around the news that was coming out of that part of the world. And we actually entered an emergency response on the 23rd of January after having been in a state of heightened alert from the beginning of the year. Throughout the course of our response, we initiated, as I imagine with all of your public health folks, case and contact management, outbreak investigation, exposure assessments, just really trying to stop the spread of initial travel cases that arrived in Canada. And these measures were largely successful at keeping COVID-19 at bay in our community up until about the beginning to mid-March. And this was especially, as I imagine Cape Town to be, the city of Toronto and the Greater Toronto Area, which the Region Appeal is part of, is incredibly connected to the rest of the world, especially the countries that saw misfortune before many of ours. China, Iran, Italy, they all count significant diasporas in our city, people that travel to and fro. And by all rights, we were expecting to see community spread far earlier on. And the reality is, in Canada, we did not start to see community spread until about earlier mid-March, which suggests to me that our contact management and our outbreak investigation procedures were working just fine up until about March, where the United States and their response started collapsing. And I recognize that many of you are in South Africa today, save and except for Nazia, who's up early with me right now. The reality is that Canada and the United States are integrated to a degree that is probably unseen anywhere else in the world. It was really telling. I still remember the day when a switch had flipped. It seemed like in early March, where our cases were no longer a handful of cases from Italy or Iran or China and some sporadic people under investigation from other countries, but where we were receiving dozens of cases a day that had reported travel to the United States, notably the city of New York, of which outside of the United States, there's probably few other cities that are as well connected to New York as Toronto is. So it was in mid-March where our province issued a declaration of emergency and a broad closure and curtailment, which actually helped to stop the spread and keep people safe. This allowed us, similar as I understand it, to similar lockdowns that were taken in your country, an opportunity to interrupt transmission, reduce contact numbers, and also buy time to develop capacity and learn about this disease. So that was taken just before St. Patrick's Day, and that was my third day on the job. So you can imagine it was a little bit of an interesting time. Our second bullet, as I mentioned, monitoring hospitals for potential cases in virus. This was essentially, like I said, what we'd been doing since January, and we'd had great success in doing so until the United States went under. And then following that, throughout the course of the pandemic in Canada, we've worked very closely with our federal and provincial partners to coordinate and ramp up capacity in things like screening, testing, and certainly hospital capacity. Obviously, we're not, as public health, we're not the lead on a lot of those things. So one of the most perennial misunderstandings that exists in our community is that we run testing. And in fact, testing is actually run through a provincial laboratory system, and public health, just like clinicians, is merely the end user. We don't run testing centers. We don't run anything to do with the actual operations of the testing system, though this has been a significant point of misunderstanding in the public and the community. And just in one of my reflections around the pandemic response, I can share it's really interesting, at least in the critical role that public health plays in keeping the community informed and safe, and my role as community spokesperson. It gives off an illusion that we have a far greater span of control than we actually do. The reality is that, as I imagine with lots of public health agencies around the world, that our work is done in coordination and in concert with other agencies, such as the provincial lab system, such as our healthcare and hospital partners. But really, we did coordinate with them as well as our provincial and federal partners to enhance measures across the realm to really aim to test, trace, isolate, and treat, and also put in place those broader public health measures, those closures and curtailments that were, at least on a temporary basis, intended to bring the spread under control, and then in the long run to lift those measures once spread was controlled to ensure that we could also mitigate some of the impacts associated with closures and curtailments in our community. So I've talked a little bit about and alluded at this, but in general, as I mentioned, public health has had a significant leadership role in addressing the pandemic, but we don't run everything. So as I've already alluded to, we don't run the testing system, we don't run hospitals, we work in partnership with those agencies. Our specific role in addressing COVID-19 has been on 5 main fronts. The first, as I mentioned, is case and contact management, which I've already discussed and alluded to. This is outbreak investigation. Really is the idea of, first of all, is the case doing well? Second of all, who do they spread it on to? And then third of all, where might they have got it from, in building out the chain of transmission? And that's similar to what your agencies do in South Africa, I imagine. And what I find so interesting, and I'd be very curious in our discussion to hear if this was the South African experience as well, is the media have really gotten into contact tracing and have discovered it. And similar to Columbus discovering the New World, they've all suddenly become experts around how this ought to unfold. Without recognizing that this is something that public health has done for centuries, if not longer. Just the most fundamental principle of infectious disease, which is you want to figure out why this person has it and stop them from passing it on to anyone else. And so I think that's been really reinforcing with the media that this is bread and butter public health has been an exercise. Secondly, of course, as local public health units with a mandate to protect our local community, we are the ones that understand the data. We're the ones that conduct surveillance and population health assessment. And so that has been a critical part of our work to address COVID-19, to target our interventions, and also to keep the public informed as to where spread is happening. Thirdly, and this will be the part of the back half of my talk, which is really out of the data and out of the course of our investigations, we do identify higher risk settings, and I think all of us have identified long-term care homes, people with pre-existing medical conditions. Protecting the vulnerable and targeting specific interventions to protect them is another part of how public health has done that, and also offering recommendations to decision makers and to our agency partners has been another avenue. Leadership, advice, I've already spoken to our role in terms of public communication and also coordination. That is essentially the last two pieces that I've identified there. So coordination with other local government and partners to fight COVID-19, and then also providing information, speaking to aspects of the response, speaking to information that the public need to know, and highlighting the trends. That is another key role that public health has played in this pandemic in Canada. And so this slide is very busy. I'm happy to just skip over it in the interest of time. But in the course of our first wave, we were actually evaluating how and why we were able to, or what were areas to celebrate as successes and areas for improvement. And these were some of the themes that were identified in terms of things that actually worked out well. The idea that there was really a focus on leveraging local partnerships and coordinating with our provincial and regional partners, early upstream interventions, as I mentioned, case and contact management, outbreak prevention, which really meant that our hospitals never ended up seeing the nature of capacity they needed, both because we were case and contact managing earlier on and managing to keep it out of the communities for quite some time. And then, of course, moving to non-pharmacologic interventions when the time dictated in March. And then certainly, digital solutions and a highly skilled workforce that have supported broad data sharing, broad public education, and then using that data to inform a whole of population approach with a focus on health equity, identifying where additional populations have needed targeting. So with that, that's kind of how things have unfolded. Those are kind of the roles that we have had in public health. And so I'm going to speak a little bit about our overall findings and experience here in the region of Peel. So the region of Peel is made up of 1.5 million residents. It's a very diverse population. Over 50% of our population, according to recent census data, was not born in Canada. So we have a very diverse population. And it's a very interesting mix of two urban local municipalities. So the cities of Mississauga and Brampton are Canada's, Mississauga is Canada's sixth or seventh largest city. Brampton is somewhere up there as well. 800,000 people in Mississauga, 600,000 people in Brampton. And then up in Caledon, which is the rural community up to the top there, which counts Bolton, as you can see in the slideshow. That's the rural community that is just on the hinterland of the Greater Toronto area. The region of Peel is basically, for many decades, had been thought of as a bedroom community for the city of Toronto, but has really been a community that's come into its own just in recent years, and also is home to the international airport that serves Toronto. So this big area here, which I'm circling with my pointer, that's actually Toronto Pearson Airport, which is ironically named because it's actually not in the city of Toronto, it's actually in the region of Peel. I think it's a lot of what we understand about the region of Peel, particularly the employment profile, the diverse makeup, et cetera, has contributed to both the fact that the region in and of its own has seen significant transmission of COVID-19 by virtue of just the number of people that are there, the number of interactions that are happening, but also in specific populations, especially given the employment profile of the community. Because of the airport being there, there's a large transport and logistics industry, there's a large warehousing industry. Because of its proximity to the city of Toronto, there are also lots of manufacturing and food processing facilities. Most of these are clustered in the city of Brampton. So you can start to see in trends, in thinking around the nature of work, the nature of the community makeup, the nature of the population, just the sheer number of people, how this might create a bit of a different context and picture in the region of Peel than even in the city of Toronto or in many other parts of Ontario that are perhaps more rural or even as urbanized, but maybe have a different employment profile and sociocultural makeup. So we did find throughout the course of our investigations that it's worth noting that because we were aware of our community's unique makeup, we recognized that we would need to collect important data on occupation as well as race very early on, self-reported race very early on in the pandemic. And so we actually started an initiation of that data collection around people reporting positive for COVID-19 almost 2.5 months before the provincial government mandated it across the province of Ontario. And this again speaks to just really the value of local public health. We knew our community, we knew our diverse makeup, we knew that the occupations in our community might put people at risk, which is why we put that measure in place, also based on the evidence that we were seeing from other parts of the world. So that allows me to present to you, and that's allowed me to present to the community what we found. And so certainly we found, at least in terms of our case data, our infection rates have been highest on the basis of age. We saw a significant phase of the first wave where there was regrettably transmission in a number of long-term care facilities and in our region, as with throughout Ontario and Canada. Again, going back to our role as community spokespeople, we don't run the long-term care home. We don't run the long-term care system as the public health unit, and obviously there were, in terms of coordination, certain homes face different challenges by virtue of their organization or their governance, and we, in the course of our response, tried our best to work with those homes to limit the vulnerability of those populations as much as possible. But certainly we did see higher cases in the 65 plus population. That was driven by the course of the pandemic through those homes. Similarly, since the course of that and all the measures that were brought in place to protect individuals in long-term care and senior settings, we then, we were in the midst of a closure. As we reopened the community, we started, not surprisingly, to start seeing the bulk of our cases in people aged 18 to 34. And I think a lot of this, initially in the media, this was reported as, oh, well, they're scofflaws, they're ignoring things, they're out socializing, partying, having a good time, especially in the midst of the summer months. But I think the interesting thing that we've also noted in Peel is that this is also the age group that is most mobile in terms of its work, and they also tend to be employed in jobs that are either precarious or cannot be done from home. So there was also a recognition that that there is transmission not only in social gatherings and social interactions from this group, but also just by virtue of their profile in terms of the nature of their employment and where they might be working, particularly if employers were not taking precautions. So that we did see higher rates in those age groups for the reasons I've mentioned. Certainly, as was seen in other parts in the United States and through Western Europe, our racialized populations also bore the course of the pandemic worse than those that were not identified as part of a visible minority. And so individuals that were that self-identified as Black, South Asian, and Latino were disproportionately impacted by COVID-19 rates relative to their proportion of the population. And a lot of this, I think, really just reflects existing health equities and disparities that were there in our population even beforehand. We know that these are many of our new Canadians. We also know that these are many of our new Canadians similar to the 18 to 34-year-old age group that are employed in places such as manufacturing, food processing, transport, and logistics, where they don't have the option to work from home and where they're exposed to different risks, particularly in the transport and logistics industry, where we do maintain a significant, crucial supply chain with the United States, and many of those people are still traveling to and from that country and its challenged response. And I've already alluded to that in terms of the third bullet, which is the big piece around certain occupations being put at risk. Again, occupations that drive and employ a lot of people in our community, but are jobs that cannot be done from home, and that if employers are not taking precautions, can result in crowded and closed environments, which can foment spread. And also healthcare, not unsurprisingly, which I think reflects infection rates that have been seen across the world. It's important to note that on an overall basis, we haven't identified a difference in incidence by gender, but what we are seeing in terms of gender is a difference when it is stratified by age. So for example, in the 65 plus data that we have, we found that women were more likely than men to pass away. And I think a lot of that just reflects disparities in life expectancy. Many of the people that were in our long-term care and senior settings were women. And then in terms of younger age groups, the people that are getting COVID-19 tend to be almost highly in men as opposed to women. Again, reflecting perhaps the nature of employment as well as the nature of behavioral decisions and approaches to life that may explain that piece as well. We also identified neighborhoods, a number of neighborhoods, and in general, neighborhoods where household sizes were larger saw more transmission just by virtue of a lot of close contact and household transmission. Usually, what we've seen and what I've described in the media has been this cycle from workplaces into homes and then into social gatherings, and it's basically this ongoing cycle. But homes are the most challenging one because in workplaces and social settings, on occasion people are taking precautions that might protect them. But in household settings, it's been a little bit more challenging because, people generally see their household as a place where they're meant to have close contact with individuals. They may take certain liberties with self-isolation, and especially if you have, what we do have is we have lots of crowded homes, both what are called multi-generational homes that are common amongst certain ethnic groups, but also we have crowded homes where people are underhoused. People are, the real estate market in the Greater Toronto area is a significant. I think it's a bubble, frankly, but really that has driven up rents, that has driven up prices. So you have a lot of people who are, again, precariously employed, at risk by virtue of their occupation, and then they may be living in crowded households with 10, 15 other people who are also differentially vulnerable. We did also see neighborhood data that suggested there were higher incidence rates in communities where there was a larger proportion of visible minorities, and also a higher proportion of the population that had no certificate, degree, or diploma, basically a lower educational attainment. These were essentially the areas where we were seeing higher infection rates of COVID-19, which I think cross-referenced with the case data really reflects just how while the virus does not biologically discriminate, the nature by which we have structured our societies and exposures does, and therefore it differentiates risk between different populations. So, obviously that's what we found. What have we tried to do about this? So as I was mentioning, in terms of mitigating outbreaks, we've targeted the vulnerable populations, long-term care homes. We've done shelter visits, and we had a couple shelter outbreaks, but in general, shelters through proactive infection prevention control have not seen significant morbidity or mortality, thankfully. So really targeting those vulnerable populations. Worth noting as well is we're working on getting voluntary isolation centers set up. This will help with the issue of people who have overcrowding issues. And then also in terms of workplaces and industry sectors, this also speaks to, addressing vulnerabilities, really trying to target certain sectors such as healthcare, manufacturing, trucking, with proactive inspections, with education, with enforcement if needed, especially if owners are not taking responsibility, with innovative outreach. So for example, with trucking, together with the province, and using the province using our data, put in place testing centers at truck stops, put in place additional measures at the border to remind truckers of the recommendation to self-isolate if they return from the United States and feel unwell. And then certainly we've also used our data collection to inform neighborhoods that could be targeted for pop-up testing, areas that might benefit from the placement of testing sites. So again, while we may not run the testing system, we do help to inform it, and we do advocate for adequate capacity to serve the population. And then finally, of course, there is communication. So based on what we're identifying, based on the patterns we're identifying, there were obviously translated messages. Our COVID-19 website has an online translation tool that translates messages into the dozen most spoken languages in our community and French. And then certainly setting up social media messages, which included community ambassadors, outreach to faith groups, outreach to other cultural groups, really in trying to reach out to these communities. Certainly there, for example, there's ethnic media, etc. So we've been also reaching out to those and trying to drive things forward. So from our data the surveillance data we've had has informed public health action throughout the course of the pandemic. And so I just wanted to explain a little bit, just in closing, before we move to the discussion, around really why we've also done this, why we actually moved so quickly to start collecting this information. Peel Public Health has identified health equity as one of our 10-year strategic priorities. We recently went through, and I think many of you will find this quite amusing, we recently went through a 10-year strategic planning process, and we came up with our 5 strategic priorities: advancing health equity, effective public health practice, healthy eating and active living, mitigating the impacts of climate change, and mitigating health impacts of climate change, and mental health promotion. And those are our 5 strategic priorities that were identified for the period 2020 to 2030. Through the course of our discussions, emerging infectious diseases had been on the list, but had not made it out of the iterative strategic process. And we launched our new strategic plan on January 1, 2020. Long story short, it's one of those cases, to quote Mike Tyson, everyone has a great plan until they get punched in the face, and that's essentially what happened with us. So we're certainly revisiting our strategic plan, just in the view of the changed reality that we have. But health equity has been one of our foci, one of our strategic priorities, and has been part of our department efforts for a number of years leading up to it being officially named as a strategic priority. And so this is the health equity lens that we apply as a learning organization, and it really is all about taking applying health equity concepts and a health equity thinking to all levels of the organization, from the staff level at an individual level, to recognize, reflect, and address their bias in their day-to-day work and in their work, but then professionally and at an organizational level and throughout our community. In professionally, really speaking to the idea of what I just said, bringing to bear our expertise in identifying vulnerabilities, identifying disparities, and the impacts that they're having. And then in the organizational piece, in terms of identifying how we then use that information and use our own understanding of our own personal bias in interpreting the provincial programs that we outline, and coordinating with other departments, and coordinating with provincial partners and with community partners. In the bottom half of the lens. So it really starts at the individual level, then speaks to what we are meant to do from a practice viewpoint, and then how it applies both within the system and then beyond the system in our community. And so that means that we're continuing to apply that lens. That means that and I'll say this as well. It's obviously clear that the COVID-19 pandemic, regrettably, is not over. For any of us. We are in Peel seeing a resurgence. However, thankfully, our case and contact management system has been able to track and trace 85 to 90% of our ongoing infections in our community, so we know where people are getting them from. And I think the steps taken by the community, in both overall as well as through the targeted interventions, has done a good job in keeping things on a slow burn. We're not seeing exponential growth, especially after our community recently reopened. We're seeing a slow burn, some linear growth, some spikes and peaks that are associated with different outbreaks. But on the whole, we're keeping things under control for now. Of course, that can change very rapidly, as has been seen throughout the world. And we're really trying our best to stave off a second wave, at least in Peel. We know that overall, from the provincial level, the province of Ontario has said that they're in a second wave. And I think this has been driven by cases seen in the city of Toronto, as well as in the city of Ottawa, as well as in other areas throughout the province that had not seen large COVID-19 burden, more rural areas that had maybe not seen the level of COVID-19 burden that they're starting to see now. But long story short, much to I think everyone's chagrin here, the COVID-19 pandemic is not over. So that means that we still have a lot of work to do here at Peel Public Health. And so we are now trying to apply our knowledge and our data and our equity lens into our COVID-19 response through a number of areas. First of all, I'll start on the bottom right. We continue with policy and advocacy. We have advocated tirelessly to increase proactive workplace inspection. We've advocated for certain restrictions and precautions and guidelines to be put in place to make workplaces safer, to address social gatherings and transmission in social gatherings, to simplify messaging, to tell people to really try to limit their close contacts to their immediate household and social supports, and really to take precautions with anyone beyond that, just recognizing that anyone is there. We've worked as well on public disclosure. There's been a significant media interest around how COVID-19 is being transmitted, how it's unfolding across the community. And as you know, public health has an important dual role in both protecting the public and issuing announcements and disclosures of potential public exposures where a risk exists, But where a risk is not identified through our outbreak management and case and contact, the typical public health practice and principle has been to protect the privileged health information of the individuals who are, really opening up their lives. These are impacted individuals with COVID-19 who've opened up their lives to help us stop spread in our community. And I think the old adage is that everyone wants to have everyone wants to know who has COVID-19 until they themselves have COVID-19. And so I've been actually very troubled by a lot of the recent media discourse that claims that public health officials are not necessarily releasing information because we're secretive or we're not being transparent. I think people have to realize that where there is a public risk, we will absolutely issue an alert. But where there is no public risk, ultimately we're relying on people who've been impacted by this terrible disease and their personal health information, and that also is a duty to protect. At least we have a duty to protect that as healthcare providers as well, especially if there is no broader risk to the public. And so we've been advocating very clearly and pushing back because, again, also recognizing that there's a lot of stigma and discrimination around this disease. We recognize knowing the groups that have been impacted and the fact that they may have gotten infected through very little fault of their own. We've been really trying to push back on a lot of noisy voices clamoring for widespread, broad public disclosure of names and places and everything that's happening with the COVID-19 response. I think it's frankly, I've been troubled because it's a little dehumanizing. I think people are forgetting that these are not just cases and numbers, but these are all real human beings. Could be our brother and our sister, and ultimately people that are often the most vulnerable in our population that have bore the brunt of this disease. And I think to put their livelihoods and their lives out in the public realm, especially if they've done everything to their best of their ability and they haven't actually done anything wrong and still got infected with COVID-19, to put their livelihoods and the names of their business at risk where there is no broader public interest or where there is public interest, but there's no public need or risk of exposure, I think is certainly a challenge. And so we continue to advocate and push back on that. And that's a lot of what we do in terms of policy and advocacy, in terms of disclosure, in terms of keeping people safe, in terms of advocating for changes that are going to keep the population protected. Obviously, interventions to reduce risk of infection in vulnerable populations. I've talked at length about getting an isolation center up and running, targeted testing, all those other pieces, and we'll continue to do that. Leveraging the data to identify vulnerabilities. We're always continually crunching the numbers to identify what we're seeing, where we're seeing it, and specific disparities that might be driving it. Certainly integrating equity into our own response sections. We're trying to, again, going to the personal lens, trying to get our own staff, especially in their exhaustion, because they've been working in emergency operations since January, to at least apply that lens to understand their own biases as they are doing investigations or as they're looking at data, et cetera, to make sure that they're double checking and thinking, am I actually looking at this with a full equity picture? And then finally, and something we've started, especially now that we've identified populations at risk, has been to include and engage key voices of the target populations of the community. It's really important for us to hear from those communities that have been more highly impacted by COVID-19 and ensure that their perspectives are included. We've done this already just recently with people who are experiencing poverty. And it was very interesting to hear, and really this tied back into this overall loop that you see here. They were saying things like, your advice is tailored to the middle class, right? It's, stay home, wash your hands. But what can you do when you don't have access to sanitizer, when you're, in a crowded shelter, or you're in a crowded house, back to back, you can stay home, but your job requires you to be in, and you're choosing between having to work and having this. So I think hearing their voices and using their stories has also been an important part in trying to inform both the interventions that we're putting in place to reduce risk and bringing the data that we've been looking at to life, but also in the policy and advocacy, and really highlighting for our decision makers why the decisions need to be taken. So that's pretty much where I'm at. I have some discussion questions here, just around whether our experience has shared any lessons to be learned for your own, and vice versa. What are some things that you've seen? I know that I know that, and I'll apologize first of all. I used to work. I used to do a lot of global health, and I totally missed the basis of this question. I think there's a lot for me to learn from South Africa as well. I think there's an importance in bidirectional learning. And previously, I used to do a lot of short-term experiences in global health. And the way the first question is phrased, I didn't put together the slides necessarily. I wanted to make it very clear that it's not a case of I don't think our response or our experience has been superior at all. I think there's lots for me to learn from you, and I'm very keen on the discussion piece. But I'm also curious to see if there's anything that you've identified out of the slides which can be of interest for discussion, and then also key equity issues that you've seen in your local level, as well as any other questions I'm happy to take at this point in time. So